We might get our last people coming in and taking a seat. So we have an action-packed session, as you will see. Lots of moving pieces, so I'm going to do my best to keep us all on track and on time. So before we begin the session, I will acknowledge the Turrbal and Yagara peoples as the traditional custodians of Meanjin. I pay respects to elders past and present, and I acknowledge the Turrbal and Yagara as the first knowledge holders of these lands. So as we begin this session, I would like to introduce our first two speakers, Kylie Radford and Lindy Moffat. And I'll just open this presentation. Okay, I'll let you introduce your talk. Thank you both.
Ginagaina Jawan, Naya Yam Lindiga, Yam Daroi Nujilinyanagagu. So I just said, hello everyone, my name's Lindy, and it's really good to be here with you all. I would also like to, from Dr. Kylie Radford and myself from the Neuroscience Research Australia team, we'd like to acknowledge the traditional owners of the lands where we are gathered today, the Yagara and Turrbal peoples of Mianj and Brisbane. We pay our deepest respects to their elders, past, present, and emerging future generations. We thank them for allowing us to be here and share the work we are doing with our communities to better the health and well-being of our elders. I'll now pass you over to Dr. Kylie Radford to start the presentation.
Thanks, Lindy. So we've got a lot to tell you today, and we probably won't be able to share it all, but we'll do our best to give you the things that we think are most important about this research. So the first thing I think it's important to know is that this is very much a process. And at this point, it's sort of processes within processes. So we've probably at about the 10-year mark, I think, in terms of this research process and where it started and where we're at the moment. So community consultation, a lot of co-design along the way, piloting, adaptation, reflecting, going back and doing it all again. And the work is very much underpinned by Aboriginal leadership, strong community partnerships and governance processes in conjunction with our sort of guiding ethical principles, I guess, around reciprocity, strengthening capacity, respect, and ensuring that there are benefits left on the ground for the Aboriginal communities that are participating in this research. So one of the starting points for us in this work, which came out of some other research we were doing around dementia in partnership with these same communities, was to get a better handle on what was important for ageing well. So for healthy ageing, we were calling it healthy and active ageing at that time, but we wanted to understand from the perspective of older Aboriginal and Torres Strait Islander people what their health concerns are, what they're worried about, but also what were their preferences around being supported to age well as they grew older. So I guess the key thing that came out of that is, a holistic approach is best, and we do hear that in many different ways when it comes to Aboriginal understandings of health. People were really worried about dementia, but they were also worried about things like falls and mobility, being able to get around and do things in their community, and also about social and emotional well-being. So certainly some themes around depression and coping with grief and loss came out strongly in that research. And this led us to start thinking about different approaches to supporting healthy ageing with these communities. And we've got sort of three key programs here, which I'll talk about briefly today. And Lindy, then hand over to Lindy, who's got some very important things to share. So first off, if I can just get this playing on here. Standing Tall is an app. It was sort of selected in partnership with a number of different groups we ran in different community settings to find something that would help support people with physical activity levels, with balance and reducing falls. So it's an app designed to help prevent falls, and it's tailored to the individual, and they can do it in their own home. And so with the app developers at the time, we worked through a co-design process there to make it more culturally inclusive. And this was supported both by older Aboriginal people as well as by Aboriginal health workers who were supporting people in the community. The second program we're going to talk about a lot, and so this will be Lindy's part of the talk, is Naranga Ginganay, which translates as Thinking Peacefully in Gumbaynggirr language. And this started life as a modified mindfulness-based stress reduction program. The third component to our sort of healthy ageing program, I guess, was health education. So we developed a series of fact sheets that would be part of the intervention as well. And these came out of a lot of the research that we had already been doing. So it was important that that was the starting point, that these were issues that were relevant to the communities that we were working with, but also supplemented, I guess, by other evidence-based material on these topics. So just briefly, this is the resulting sort of program or study design, and this in itself was very much a collaboration. So us as the researchers originally had this very complex sort of RCT with different arms, and we were going to tease apart all the different components and how effective they were, and our community partners very quickly said, no, that is not going to work, and we're not going to support that. So it was a process then to work together to say, well, what's going to be feasible and acceptable to the communities, at the same time as helping us to, I guess, achieve some of the scientific aims and build the evidence base around these programs that will be important, of course, for ongoing funding and sustainability. And a big focus was to ensure we had good evidence base around Naranga Ginganay in particular. So there's a sort of embedded waitlist control design there. So briefly, some preliminary outcomes. Certainly throughout this whole process, flexibility, responsivity, co-design have been key elements. We've finished recruitment now for the trial, which we didn't quite get to our 100, but 99 participants is pretty good. And in about sort of less than 12 months, I think it ended up being, with all the delays with COVID and the like that this project experienced. People are aged in their 60s on average, mostly women. A bit of attrition, which we'll be looking at closely to understand the factors contributing to that. Very strong community engagement, particularly around this Naranga Ginganay component. I mean, we've sort of far exceeded, I guess, the number of different community organisations that we're now working with. We didn't quite anticipate such a strong response. So hopefully that will continue on into future. More mixed sort of findings, I guess, around the other components, which I'm happy to talk to someone about later. But we'll be looking very closely when we finish our follow-ups at a key outcome being quality of life. So using the What Matters to Adults tool, an Aboriginal quality of life tool, as well as looking at social and emotional wellbeing, cognitive outcomes, physical health outcomes, and engagement. And now I'd like to hand over to Lindy, who'll tell you more about this component.
Yes, so as you can see with Naranga Ginganay, Thinking Peacefully, it was 8-week, there was one session each week for 8 weeks with the elders. So I've been facilitating Naranga Ginganay since 2019 with over several communities. So as you can see, I won't go through all of that. For each week there was a different topic as well. Which one? This one? With each community, we needed to adapt to each community, different languages, different cultural protocols and practices. So that took some time. So when we were doing that, the program was running and it was sort of evolving and changing as we went through it. So you can see on the chart there the sort of things that we had to do, engage with local artists, expert language translators and so on for each community. Some of the adaptation outcomes were on Dungari country. I trained a male facilitator because it became not appropriate to have male and female in the same sessions, because as we'd go through the teachings, there were different responses from males and females. So, yeah. Mindfulness became more than that. It was the connection for everybody to keep with their, let's go back. Just cultural expressions, ongoing sharing of stories, poetry and writings that people would do, art practices, language practice, being on country, and just flexibility responses as well. So I guess some of the, looking back at it, some of the challenges were, sometimes low participation from elders because elders have many responsibilities with their family and communities. They may be unwell. So there were challenges there for sure. Successes were that, the groups became a social network for people to keep up with the groups and stay with each other and ongoing support of the elders. One of the successes too was in a community where the local Aboriginal Medical Service has funded the Naranga Ginninay to keep going, to keep running in the community. And just staying strong to age well. So Naranga Ginninay to continue as a standalone program with several services, implementation packages to enable widespread access of Aboriginal community-controlled health organisations. And also we're looking at publishing a creative booklet with all the writings from participants and facilitators from the Naranga Ginninay program. Standing Tall will soon be available through the App Store. I don't know, it's gone.
No, that's all right.
I can't see it properly.
We've done that one. So this, I think we've blitzed it in terms of time, Lindy. So I'll just say that this photo is from one organisation who have, taken it on as their own program now. They're running it. This is the T-shirts that they designed specifically for that new program. So very exciting to be at the launch there. And I guess the final slide is just to say thank you. And I mean, huge thanks to Lindy, because I think that it is through her sort of leadership and facilitation of Naranga Ginninay in particular that has really brought it to life and taken it to places we didn't expect it to go, and it's going to continue to grow and grow, I'm sure. And just to thank again all of our team, our community partners, and of course the participants that took part. Thank you.
So don't go anywhere. You do have a few minutes for questions. So we do have a roving mic at the front, and I'm sure we probably have some questions, I imagine. Very exciting research. An amazing translation. That's really, seeing some really meaningful engagement, and that's exactly what research is all about.
Oh, just beautiful work, just heartwarming. I might have missed at the beginning, what area of Australia are you working within, and does it also translate well, you think, into the metro areas as well? Would you like to comment on that?
Yeah, that's a good question. We were so worried about going over time that we really, kept our slides very tight. But normally I do put up a slide that has a nice map so you can see. This work in particular has been done in New South Wales. So it does include metro communities and quite a few different organisations actually that would be in your health district, Wendy. And also some more regional communities, and particularly up on the mid-north coast, which is where sort of Lindy's from, where the Naranga Ginninay program, I guess, was originally developed, so on that Gumbaynggirr country. But we have, from the beginning, I guess we wanted a model that we could move around and adapt according to the local context. And I guess maybe I'll just let Lindy talk a little bit about that, because that was a really key part of the original design of the program too, that it would be co-led with elders and that there would be space for adaptation. Do you want to say anything more on the local adaptations?
Yeah, it was working with the community and the local elders to do the adaptations. It was really necessary because it then gives that community ownership of the program. So, yeah, and it worked well. So we've worked with communities on the mid-north coast and also in Sydney. Yeah.
Great. So we'll chase that up, because our team's in the space now where we can start doing some partnership work. So we'll be looking at that. Thank you very much. It's very exciting.
Thank you.
I think we're actually out of time, unfortunately, so I'm sure you'll be able to catch our presenters outside after the session. So we're going to move on to our next presentation. Okay, so I'd like to welcome Fofi Konstantinidou.
Hi, good afternoon, thank you. I'm Fofi Konstantinidou, coming from the University of Cyprus, from the island country of Cyprus, and I will be presenting an aspect of our longitudinal study on aging, which used a preventive approach to cognitive decline using a multidimensional screening tool. Let's see. How do we advance? Oh, we have a pointer. Awesome. Okay, these are my disclosures. So I come to you from Cyprus just to kind of show the location in the event you don't know where it is. It's an island country in the southeastern Mediterranean. It's actually the furthest southeast country of Europe. So according to Google Maps, we're about, several kilometers away from each other from Australia, so close to 15,000 kilometers to come here. So I'm very excited to be here, my first time in Australia. So I come to you from the Center for Applied Neuroscience. Let's see, it's not responding very well. Maybe I'll go page down. I come to you from the Center for Applied Neuroscience. I'm the founding director of the center. We established it in 2011 through competitive funding. And the mission of our center is to develop research and technologies that inform science, but also help health and quality of life for the citizens. And the issue of aging is a prominent issue in Europe. I know it's also a prominent issue in every country and every continent, but the number of people living over the age of 65 continues to advance. And so our need to understand factors that affect and prolong aging, and with that cognitive aging, is really of paramount importance. And we know that there is a trajectory of change in cognitive function with aging, but that's a very, subtle change that allows us to live productive and meaningful lives. But yet there is a cohort of people that seems to develop cognitive decline. And the need is to identify the factors that affect cognitive aging, and what are those factors that render some people more vulnerable to cognitive decline than others. So when we embarked on this line of research, I was still working at Miami University in the US, where we published our first study comparing healthy older adults to younger older adults on the AVLT. And we reported that even though there were significant differences in the absolute number of words gained per trial, the trajectory was very parallel. And the difference was about 1 standard deviation, which is what's been reported in the literature, right, in terms of healthy aging. But let's make this real. Let's talk about a real person. So this is a person from our study, Mrs. Monica, who is a retired nurse. She has developed episodes of forgetting names, appointments, and chores in the recent months. She's also got lost while driving a couple of times. She's very concerned because, like every self-respecting grandparent in Cyprus, she takes care of grandchildren. So she was very concerned about taking care of her grandchildren and became distressed and withdrawn. So here we have a health problem that potentially impairs quality of life and also could cause secondary health effects. And so what do we do with a person like Mrs. Monica? So here's where our study, the neurocognitive study for the aging, comes in place. It is the first longitudinal and only longitudinal study on cognitive aging in Cyprus. We started this project in 2009 through competitive research funding, and we've been able to maintain it through external funding through the years. And the mission of the study is to investigate factors that contribute to brain health and advance scientific knowledge in the field of cognitive aging. But then through this project, we have engaged in a number of activities that are promoting brain health and empowering citizens. We do assessments and monitoring. We engage participants in clinical trials. We do a lot of public outreach, a lot of educational materials for the public, in addition to the scientific dissemination. So we want to determine modifiable and unmodifiable factors that are risk for dementia. And those of you who are studying this scientific space, you know of the most recent publication of the Livingstone et al. Group, where the modifiable risk factors for dementia now are up to 45%. This is a very powerful number to consider that we really have a role to play in preventing pathological cognitive aging. So our study incorporates a multi-domain predictor variable process where we examine neurobiological, psychosocial factors that can be used to predict the progress and outcomes of aging. So in the study, we have about 1,000 volunteers accumulated through the years. It's a rolling admission process. We reassess individuals every 2 years. So now we have a cohort that we've been following for 14 years. And the protocol is extensive. It's about 90 minutes of testing. It includes verbal learning, short-term and episodic memory, language, executive functioning, attention, and then we have psychosocial indices including depression, quality of life. We have informant information with the AD8 and this executive questionnaire. So it's a pretty comprehensive battery. In addition, we collect anthrophysiologic measures like blood pressure, weight, BMI, and other factors affecting cardiovascular condition, and also some blood work and other indices. And so through the years, we've been able to accumulate different levels of evidence about different factors. So for instance, strong predictors for healthy aging include age, cognitive reserve, education. Moderate evidence, we've been able to demonstrate factors such as hearing loss, glucose and diabetes, BMI, mental and social engagement, mood, quality of life. Those we have moderate evidence on those, and then emerging evidence on the contribution of ApoE4, which is very low. The incidence of ApoE4 in Cyprus is one of the lowest in Europe. And so we've contributed our early studies looking at age and education effects. And also this project for us has been a way to obtain normative data which were absent on a number of different neurocognitive and language measures in Greek and in Cyprus in general. And so we've been able to show that there is cognitive stability for people who enter the study and they are cognitively healthy. We've looked at the role of the metabolic syndrome factors, and we've also done a number of studies looking at the effects of age and education, and most recently looking at different treatment modalities. And so modifiable factors such as hearing, glucose, BMI, mental and social engagement, mood, quality of life seem to have an effect on cognition. And in our cohort, with each wave, we've been able to identify between 4 and 9% of the cohort being at risk for dementia, comparing their performance to their age-appropriate norms, seeing a change from their previous assessment. So the WHO, as you know, has provided guidance on person-centered approaches to aging, and taking what we've learned from the NeuroAge project and what the current guidelines are, we developed a multimodal screening protocol. We wanted to evaluate the feasibility of multidimensionality in screening process in older adults in urban and rural areas. We wanted to examine the predictive role of sociodemographic, nutritional, hearing, resilience, and the effects of long-term COVID-19 on mental health. And so our protocol consisted of the Mini-Mental, the GDS, Geriatric Depression Scale, the Geriatric Anxiety Inventory, the Hearing Handicap Index, the Mini Nutritional Assessment, and long COVID symptoms. We've recruited people from all over Cyprus. Cyprus has a population of about 1 million. So it's a small island country. And we had about 800 participants from different areas. We have identified that about 22% failed the Mini-Mental, 15% the GDS, 29% the anxiety inventory, 21% the hearing handicap, and 24% the nutrition. So those were the percentage of people at risk for each of those domains. In terms of associations, of course, age was associated negatively to cognitive status, but so was depression and hearing difficulties. Education, good nutritional status, and coping skills were positively correlated with cognitive performance. And then in logistic regression, age, education, and nutrition were the significant predictors in that model. Then looking at the people with prolonged symptoms of COVID-19, 23% of those with COVID, which was about a quarter of the sample, had persistent symptoms with fatigue, sleep disturbances, cough, concentration, and headache being the most prominent symptoms. We saw that for those individuals, significant predictor for cognitive performance was age. The prolonged symptoms was not a predictor, but this is something we need to continue to follow. So the results show that the screening was a feasible approach to detect individuals at risk for conditions that we know affect cognitive health. The findings with the NeuroAge sample indicate that the contribution of good nutrition and higher education to cognitive performance, hearing handicap, correlated with cognitive performance, and self-reported symptoms of COVID-19 were not associated with cognitive performance in the present sample, but we need to follow this further long term. So the findings underscore the value of brief and multi-domain screening protocols to successfully identify modifiable risk factors for cognitive decline. It's feasible, scalable, and cost-effective. And it also points to the need for timely referrals to improve cognitive aging. So back to our Mrs. Monica example. In her case, because she was a participant in our study, we were able to do extensive assessment, medical referral for further workup. She participated in our cognitive training studies, and was able to maintain her quality of life, which we know early detection is a significant time-saving factor. Would invite you to our poster on Saturday. We will talk more about one of the treatment protocols that we implement, which is hierarchical cognitive training program, the categorization program. And I want to close with some policy considerations. This study is in line with the UN Sustainable Development Goals because we know that prevention of cognitive decline is cost-effective. The timely diagnosis also is cost-effective, but it also promotes health and quality of life for patients and their family. And the research to develop effective pathways is important, and rehabilitation is a human right. So I want to close thanking the participants and also members in my lab and our funding sources through the years. And I want to briefly wear my hat as president of the American Congress of Rehab Medicine to invite you all to the ACRM conference in Chicago, end of October. We'll also be offering an online pilot program that will be announced soon. And I want to thank you. And if any questions, this is my contact information. Thank you.
So what a fantastic presentation. Thank you so much. We might have to move on. So unfortunately, Fofi, we don't have time for questions, but I'm sure you can find Fofi after the session. Our next presenter, we're moving on to some quick data blitz sessions. So I'd like to welcome Sarah Hascart up to the stage. Thank you.
You. Oh, can you hear me? Cool. So I'm about to talk about one of the PhD studies, part of my broader PhD, about young to midlife adults' knowledge and engagement in dementia risk reduction. So as we know, dementia is a general term for a decline in cognitive function that interferes with daily life, encompassing various symptoms, including memory loss, difficulty in communication, impaired reasoning, and etc. And it poses a significant global challenge. So as people live longer, the number of people living with dementia also increases. Currently, dementia affects 57 million people worldwide, with projections of 53 million affected by 2050. And research suggests that 30, and as Fofi said, up to 45% of cases can potentially be prevented by addressing some modifiable risk factors or protective factors throughout the lifespan. There are some crucial points across the lifespan that are important to focus in. For example, midlife to later life, as you can see, the factors are increasing there. But the translation of this to the general public shows that there's poor awareness and knowledge of this within the general public. And researchers also only focused on asking older adults what they know and what they're engaging in terms of their risk factors. So the aim of this study was to address or assess young to midlife adults, their knowledge of dementia risk and protective factors, what their current health behaviours were, and their intention to change any behaviours that they had to reduce their own risk. So just a quick touch on my method. It was a cross-sectional survey of 616 Australians, so 49% female, and I assessed 18 to 44-year-olds, so with a mean age of 30. The knowledge questions were on a certainty scale, so I gave them true, probably false, and don't know. And then I asked them about 10 of the health behaviours that the Lancet Commission said in my previous slide that were risk factors. And then those who said they weren't engaging in those behaviours, we asked if or when they intended to change that behaviour. So just a quick look at my key results. So just for the purpose of time, I won't go over all of the knowledge questions, but overall, accuracy for their knowledge was only 45%. But importantly, their engagement seemed to be okay. So about 70% of my participants were engaging at least in 5 of these behaviours. So just to explain my graph here in terms of the engagement in dementia risk reduction behaviours. The green is people currently engaging, the yellow is people not engaging but intending to change their behaviour, and the purple at the top is no intention to change and not engaging. So as you can see with a couple of these factors, such as that there are 90% not smoking, which is really good, people saying that they're not playing contact sport or they are wearing at least protective headgear. And then we asked them if they were being mentally active between every 6 months to 1 year. But as you can see down the end here, they're not checking their blood pressure, they're not checking their cholesterol levels, or they're not checking their blood sugar levels. But this sort of makes sense because my mean age was 30, so you can probably assume that they're not going to the doctor that often to check those sorts of things. But their intention to change this was promising. So I won't touch too much on my intentions to change, but I'll focus on the engagement. So a lot of them on par with what they didn't know. They weren't aware or weren't engaging in wearing protective earwear, or were still happy to just sort of risk that factor. But for the purpose of time, just to wrap that up, knowledge remains poor, but engagement in health behaviours is variable. And let me go. But with the intentions being so promising, there is an opportunity here to target that younger audience so that they know more about what they can do to have their dementia risk reduced, and also to live longer with their brain health much stronger as well. So I will just end it there. Any questions later, see me at my poster. Thank you.
Okay, next up we have Marina Cavorto.
Thank you. So this work was conducted at Monash University and the National Ageing Research Institute, and the background is that dementia disproportionately affects the disadvantaged, including people who live in areas of lower socioeconomic status. We found in our previous research that even in midlife, living in areas of lower socioeconomic status, or SES, is associated with an increased dementia risk factor burden and poorer cognition. So we're interested in exploring the features of neighbourhoods that might underlie that association, and we had a particular focus on green space, neighbourhood walkability and crime. There's an emerging body of literature showing an association between green space and brain health. There's quite mixed findings and mixed variability, mixed methodology in the approaches, but that sort of body of knowledge is growing. There's evidence for an association between neighbourhood walkability and health, things like BMI, obesity and physical activity. And there's a handful of studies showing a relationship between crime and mental health and cognition, but that's really in its infancy. So we used data from the Healthy Brain Project, which is a prospective longitudinal cohort of 40 to 70-year-olds who are free of dementia at baseline. We took their baseline measurements and looked at neighbourhood characteristics that were available at the level of the postcode. So for green space, we had two measures. One was the percentage of parkland available within their postcode, and the other was the average distance to the nearest park. For walkability and crime, which we only had data available for the state of Victoria, we had street intersection density per square kilometre within the postcode, and crime was the rate of recorded offences. Our outcomes were the Katie Dementia Risk Score, which includes hypertension, high cholesterol, BMI and physical activity. Our primary outcome was computed without age, sex or education because we wanted to look at the more readily modifiable factors. For cognition, we used the Cogstate Brief Battery, which was administered remotely and unsupervised. So we were able to get representation from all Australian states and territories and regional and remote areas as well as metro. And we took the attention and memory composites. Our moderators were neighbourhood SES and rurality, and covariates were age, sex, education and personal SES. We found that a longer distance to green space was associated with a higher modified Katie or dementia risk factor burden, but that relationship was only present for those living in lower SES areas. We found that higher crime was associated with a higher modified Katie and poorer memory. We hypothesised that this could be due to behavioural responses to the local environment. So if you live near a park, you might be more likely to exercise, or if you feel safe in your community, you might be more likely to exercise or socialise and feel more connected to the community and less lonely. Alternatively, it could be the reverse, because this is a cross-sectional observational study, so it could be that those people who are better resourced, have more education and better cognition, are more able to choose to live in more desirable neighbourhoods. We did account for personal SES and education in those models, but of course residual confounding remains. So future research is needed to unpack this a little bit further, understand the length of exposure, how long people are living in neighbourhoods, what relationships are like longitudinally, and of course to get more diverse populations, particularly with respect to SES, ethnicity and health literacy. But nevertheless, this body of research into neighbourhoods and health is growing, so it gives an opportunity for clinicians, researchers and policymakers alike to think about some of the structural barriers that might impede people's adherence to health advice to live a healthy lifestyle or dementia prevention programs and the like. And this was published in Preventive Medicine Reports last year. Thank you.
Thank you. Okay, next up we have Caroline Gurvich. Welcome.
Thank you very much. So I'm going to be speaking about menopause and cognition. So just so we're all on the same page, for females across their lifespan, they have reproductive years from puberty up until sort of mid-40s for most people. And this is, for people not on hormonal contraceptive, defined by endogenous cyclical fluctuations in sex hormones, the menstrual cycle. Then we have this phase called perimenopause, which is a transition period. This can last for 4 to 10 years in most women. Then we hit menopause, which is a single day defined as 12 months following someone's final menstrual period. And that perimenopausal timeframe is characterised by quite unpredictable and rapid fluctuations and gradual decline in estrogen and progesterone, after which time people are postmenopausal, which is characterised by low levels of estrogen and progesterone and high levels of our pituitary gonadotropins, luteinizing hormone and follicle stimulating hormone. And why this is relevant is because these sex hormones do a whole lot more than regulate our reproductive function. They also cross the blood-brain barrier and have effects in our brain. So most people experience some symptoms during the menopause transition, and I'm just going to touch on the cognitive symptoms. This was a study where we asked women about the cognitive symptoms that they experienced that are often referred to in the lay terms as brain fog. And this sample is not representative of the general community. It's people who are experiencing cognitive symptoms. And of the cognitive symptoms people experience, it's things like poor memory, difficulties concentrating, mental fatigue, difficulties planning and organising, difficulties making decisions that seem to be most prominent. And in terms of how bothersome these symptoms are or their severity, on a scale of 1 to 7, people are sort of somewhere between 4.5 and 5, which is a lot higher than, for this sample, how bothersome their more traditional menopause symptoms are, like hot flashes and night sweats. We then validated an existing scale in a perimenopausal cohort. It's called the Everyday Memory Questionnaire. It's 13 items, and of the items in our cohort, they loaded onto a retrieval factor and an attentional factor. And when we looked at this cross-sectionally, we found that both retrieval and attention were poorer in perimenopausal women compared to reproductive age and postmenopausal women. And the most common symptoms of this scale that perimenopausal women reported was that experience of having to check whether you've done something that you should have done, and that tip of the tongue or word retrieval difficulty. We then developed with our statisticians some cut-off points, so we had some actual numbers to define what was considered intact or impaired retrieval and intact or impaired attention, so then we could start to correlate this to other factors. So one factor we were interested in is whether this is associated with objective neuropsychological performance. So keeping in mind that neuropsychological performance is generally within normal limits in this perimenopausal cohort, there is still a significant association between those women who have reported impaired retrieval or impaired attention to neuropsychological performance on areas of verbal learning and recall for both attention and retrieval, and verbal fluency, which kind of relates to that word retrieval, tip of the tongue phenomena, and working memory for the attentional domain. So just to finish, there are lots of potential factors that contribute to this subjective experience of menopausal brain fog. So some of those are likely to be the neuroendocrine changes from the sex hormone fluctuations, decline, loss of the neuroprotective effects of estrogen in the brain. And then there are other factors related to menopause, like poor sleep, depression, anxiety. Those factors are more common menopause symptoms that independently might contribute to the experience of brain fog. And then there are other processes independent of menopause, like ageing, midlife stress as well. So I'm going to finish there, but thank you very much for listening.
Okay, so for our next session, we're moving back to some more oral presentations for you. So I'd like to welcome Jacqueline Owens.
Thanks, Fee. So I'm Jackie. I'm a neuropsychologist who works at Calvary Healthcare Bethlehem, which is a hospital in Melbourne, and I work in the outpatient clinic that sees people with progressive neurological disorders. And so one of the questions that we often get asked is when someone might be time for someone to stop driving, and when might be a time for someone to go for an on-road driving assessment. So today I'll be looking at the preliminary research that we looked at between the association between an app called the Drive Safe, Drive Aware app and the outcome of on-road driving assessments in progressive neurological disorders. So as we know, driving is fundamentally tied to independence and quality of life, and dementia significantly affects cognitive processes that are essential for safe driving, such as executive skills, visual spatial skills, attention, memory, processing speed, and so on. So while skills may be retained in the early stages, with progression and progressive impairment, inevitably this creates unsafe conditions for driving. And as we know, driving errors can have catastrophic consequences, thus assessing individuals with compromised cognition is essential to maintain road safety. So on-road evaluations at the moment are done by independent OTs, and they're considered the gold standard. However, they can require significant resources, time, and sometimes it can be difficult for people to access. And if people can't get this funded through NDIS, then they're paying out of pocket as well. So having clinical off-road assessments can be valuable as a screening tool to determine when someone needs to go for an on-road assessment, which can help to reduce the amount of assessments needed. So currently, most of the existing off-road assessments have their limitations. So traditional tools like the MMSE and the MOCA show variable and often inadequate sensitivity and specificity. And also things like the MOCA can creates a massive indeterminate range with scores between 12 and 27, which is almost the entire range. Similarly, Trails B can be associated with driving assessments. However, again, a lot of people are falling in that indeterminate range. And then a study looking at combined batteries found that there can be variable sensitivity and specificity, but these can be very resource heavy and needing neuropsych evaluation, which can come with wait times and so on. So this brings me to the Drive Safe, Drive Aware app. So this is an iPad-based application. It takes around 10 to 15 minutes to administer, and you administer under the supervision of a healthcare professional, but the person sort of completes the assessment themselves. So it has three components. The Drive Safe component, which is visual recall of 10 intersection scenarios, where people have to recall the placement and direction of things like bicycles, cars, people, and so on. There's also a Drive Aware section, which is asks 7 questions around the person's awareness of their own driving ability, which is done by interview. And there's an optional intersectional rule component, which looks at people's knowledge of intersection rules, essentially who needs to go first in an intersection. So there's been research into this app that have mainly been done sort of in mixed samples of people who are older, but also people who have neurological disorders. So the research that the Drive Safe Drive Aware app has put out says that it's got 91% sensitivity and 86% specificity, which is better than the measures that I just mentioned. And so in terms of how it's scored, well, the app does the scoring and sort of spits out a report for you. So people who are in the lower range of the Drive Safe scoring and lower range of Drive Aware, obviously they're scored as likely to pass. Then there's the range in the middle of people who have got mixed scores, and then the higher range of people who are scoring highly on the Drive Safe and also on their Drive Aware are put in the more likely to pass category. So the reason we want to look at it in our sample, well, progressive neurological disorders are complex. These disorders often come with multiple complexities, such as variable disease progression between individuals and between conditions, multiple domain impairments affecting motor, cognitive and behavioural simultaneously, changes to insight which can occur early on, particularly in FTD and HD, which might sort of show up before more significant cognitive impairment shows up on testing. And that's, of course, important for good judgment while driving. And given a lot of the disorders we see at our clinic are associated with young onset dementias, many of these people are still very active, they're driving, some people are still working or have family responsibilities, so are dropping off kids and things like that. So it's an important group to be looking at driving. One, for safety, but also so that we can help with proactive planning and ensure that people have the right support so that we can maintain independence whilst preserving safety. So our study aim was essentially to investigate whether the DSDA was effective in predicting how someone would go on-road assessment, so that could provide us with more information about if this is an effective tool to use to know when to send someone for an OT driving assessment. And just to make a note that this is very preliminary analysis, looking at a small sample size in our retrospective data. So we had, so looking at the participants that we had, so a lot of the people we see through the clinic, it might have been very clear that they were going to pass an on-road assessment, so they weren't referred for an on-road assessment, or it might have been very clear that they were going to fail. So they either were told to stop driving or decided to stop driving themselves. So these are the people we had both data points for, so that's sort of grey area where it's a little bit more difficult to determine. So it was a retrospective convenience sample for people who had clinical concerns regarding their driving ability and who had completed both the DSDA and an on-road assessment. So the age range was between 38 and 76. The group of 12 was mainly HD, but there was one MND FTS, one MND FTD, and a myotonic dystrophy as well. It was predominantly male, with 10 out of the 12 being male and 2 being female. So essentially people were referred for neuropsychology assessment because of identified cognitive difficulties along with concerns around driving. The DSDA was administered along with the neuropsych assessment. And on-road assessment was recommended based on clinical judgment, so not just on the DSDA scores alone. The assessment on road was done by OT driving assessors that were independent from our clinic, and then we were able to sort of get the data and have a look at how they married up. So in terms of the differences between the pass group and the fail group with regards to the on-road assessment group, the mean age was about 53, 56, so that was similar across both groups. There was a significant association between the Drive Safe score and whether or not people will pass or fail the on-road driving assessment. And there was some trends towards significance with regards to the Drive Aware score and the time it took. However, that didn't reach significance in this small sample. But just to note that they no longer include this variable in the reports, but in the previous reports they did with the Drive Safe Drive Aware app, but both groups were taking significantly longer than what was originally reported in terms of how long it should take to complete the assessment. So looking at how the outcomes of the Drive Safe Drive Aware scoring married up with the outcomes of the on-road assessments. So the app was able to predict to some degree, that whether people were going to pass or fail the on-road assessment, but it certainly wasn't perfect. And the sensitivity and specificity was much lower than in the other studies that have been done in the past. So although that sensitivity and specificity was low, we did have that significant finding about the drive safe score. And really it sort of indicates that because we don't want to be missing those false negatives, because that obviously has significant consequences for safety, what we've sort of found is that people who are passing the passing the Drive Safe Drive Awareness app, if they've got low Drive Safe scores, that might be an indication that you need to look further into it, and that certainly the Drive Safe Drive Aware app doesn't sort of replace a more comprehensive assessment. So in terms of qualitatively looking at the two individuals who passed the Drive Safe assessment but failed the on-road assessment. So they were the two assessments were approximately 4 months apart, which does sort of reflect real life timelines, in the sense that it's not always, people can't always get assessments right after. So in progressive neurological disorders, obviously things could have changed in those 4 months, but also need to take into account that the people who failed the on-road assessment were generally slower to complete the Drive Safe, Drive Aware. So it sort of supports that it needs to be a multifactorial analysis when looking at driving capacity. So overall, clinically, DSDA was found to be associated with on-road outcomes in progressive neurological disorders. However, it should be used in conjunction with other assessment methods in determining whether an on-road assessment is needed. Given our 60% sensitivity, it's crucial to consider processing speed and other neuropsych measures, along with the other clinical information like clinical history, collateral history, and so on, to make sure we're minimising the false negatives and ensuring road safety. So the other thing that came out was that there was, in the individuals who failed the DSDA but then passed the on-road, both of them had higher DS scores but lower DA scores, indicating that perhaps that was the insight was one of the key symptoms that was deteriorating first. And that might be something that's harder to pick up in an OT driving assessment. And one thing I've noted just looking through the data is that often the OT assessors might just get a report with either the diagnosis or something saying cognitive impairment. So perhaps enhanced communication between referrer and the OT assessment, particularly for those more subtle changes, will be important to make sure we're getting proper assessments, as that could affect outcome on the day, but also recommendations with regards to how soon they should go for a follow-up assessment. And finally, I guess just anecdotally, with regards to our service, another benefit of using the Drive Safe, Drive Aware app is we find that it is a good way to have a conversation with people around driving, and that certainly it supports our medical professionals in talking to our clients around when to stop driving. And I think it holds a little bit more weight for some clients with regards to their understanding around the validity, seeing it's specifically looking at driving. We find those conversations can go a little bit easier when using this assessment tool, rather than something that might seem a bit abstract to an individual with regards to sort of neuropsych assessment in general. So in terms of limitations, well, we did have a very small sample size and limited statistical power. There was a big interval between the two assessments, which might reduce the predictability of the DSDA. So it would be good to be able to continue to collect this data, and to sort of look further into it, and once we've got a larger sample size, have a look at the full picture in terms of what neuropsych assessments might be associated, but also maybe even looking at motor vehicle accident data as well, just to get the full picture. So that's the ends, and just thanks to Fiona Fisher and Marie-Claire Davis and Ji Shen, who also helped along with the participants as well.
So I think we have one question, if anyone has a burning question before we move on. Okay, well, thank you so much, Jackie. We have our next oral presentation. So, Sauchi Chung, come. Here we go. Is our link? That should- Oh, no. Hold on, no, we have to go back to, no, that's what he said. Hang on. Yeah, I think that was, sorry, slight technical difficulty. We are,
Do you need your phone? Honestly, every time I touch technology, it just breaks. Hello, everyone. I'm Candy. I'm from the Frontier Research Group in Sydney, and I'm just going to be talking to you briefly about one of the projects that we've been looking at to look at the interplay between frontotemporal dementia and autism. So what is frontotemporal dementia, or FTD? It's a younger onset dementia, which means that it typically presents before the age of 65. There's various syndromes. So one of them is behavioural variant FTD, and then we've got the language presentations, which collectively are known as a primary progressive aphasias. And then within that, we've got semantic dementia and progressive non-fluent aphasia. They all present very heterogeneously, have their own characteristic symptoms, but for the purposes of this presentation, I'm just going to be focusing on BVFTD. So BVFTD is characterised, as you would expect, by personality and behaviour change, and there's also known to be poor social cognition and empathy as well. Cognitively, we often see executive dysfunction, especially inhibitory control, and collectively you just get those poor social behaviours and interactions. There are functional and structural changes known in BVFTD, particularly in the frontal lobes, so the insular and medial frontal areas and the orbitofrontal areas, as well as the anterior temporal regions. And usually from diagnosis is about a 5 to 7 year survival estimate. Symptoms do present well before that. So within BVFTD, there is a syndrome called phenocopy or atypical FTD. I'm just going to be referring to it as AFTD here. So what is that? So AFTD shows a very similar clinical profile to BVFTD, but it's a much slower progression. So we see over the same amount of time, a minimal change in cognitive function, as well as brain atrophy. And typically, people we've seen with suspected AFTD in our clinics, they've also scored quite well on the ACE3. A lot is unknown about AFTD, hence why we're looking at it. And one of the theories is that could it actually reflect underlying high-functioning autism that hasn't actually been diagnosed, and the symptoms are emerging with aging when they start to lose the capacity to compensate and camouflage for the difficulties. So why AFTD, which is neurodegenerative, and why autism, which is neurodevelopmental? They do share a lot of similar aspects, so especially in that social cognition area, so the emotion processing, changes in empathy, poor theory of mind, and both show executive dysfunction, especially with that cognitive inflexibility and the rigidity as well. Within the brain, there's also structural and functional changes that are known to be playing a role in social cognition. So in BVFTD, there's changes in the anterior temporal and orbitofrontal regions, and more recently there's been a study has found that there's structural and white matter connectivity changes in the amygdala bilaterally. In autism, there are changes in the left amygdala, the fusiform face area, as well as the cerebellum. So our group, we wondered, well, what is the relationship between BVFTD, AFTD, and autism? And we had two primary hypotheses. The first being that BVFTD should perform worse than the other two groups on all the measures. And secondly, based on literature and what we know about AFTD and autism, those two groups should actually perform quite similarly to each other. So We recruited participants from Frontier, the FTD research group, and our collaborating research group, CAN Research, which is an autism group. And we had participants with BVFTD, suspected AFTD, autism, and also 31 healthy controls. All participants went through comprehensive neuropsych assessment, so that included the cognition and social cognitive measures. They did a lot of questionnaires, and we had informant questionnaires as well. They also did the ADOS too, so all the diagnostic groups, so the BVFTD, AFTD, and autism underwent the ADOS too, which is the Autism Diagnostic Observation Schedule, which is considered the gold standard diagnostic assessment tool for autism. And everyone also underwent structural brain imaging and also a blood test for blood biomarkers as well. So this is, if we look at some of the cognitive measures, we had a lot of tests, so I haven't included all of them, but we see that in comparison to controls, BVFTD do show quite a lot of impairments, and more so than the other groups. Autism actually perform quite similarly to control groups, and the AFTD group, they have quite a mixed presentation compared to control. So here we can see that AFTD and autism do show quite a lot of variability in the cognitive measures. Interestingly, we looked at the questionnaire measures as well. So we looked at the depression, anxiety, and stress scales of the DAS-21, and the autism quotient, the 10-item one, the social responsiveness scale, as well as the social interaction anxiety scale. So unsurprisingly, the autism group had highest level of autistic-like traits, but the other groups didn't really differ from controls. On all the other measures, autism also scored higher on depression, anxiety, stress, social responsiveness, and higher social interaction anxiety. But the other two groups didn't really show that. So if we just come back to our hypotheses, where we thought, well, BVFTD should perform worse on all the measures than other groups. If we take the cognitive measures, at least, that hypothesis is supported. When we look at the AFTD and the autism groups alone, however, hypothesis 2 is not really supported. There's really mixed findings. So we looked a bit further into the data, and we looked at some ROC curves based on some of the measures, looking more specifically between the AFTD and the autism groups to see what actually differentiates the two groups. And interestingly, we found that the social responsiveness scale, which is the top left, social interaction anxiety scale, which is the blue line, a quality of life measure, so it's the World Health Organization quality of life measure, but it's only the environment subscale, and then the stress subscale of the DAS-21. These four measures were the best at differentiating AFTD and autism. And it's really interesting to see that none of the cognitive measures that we typically do in a neuropsych assessment or an autism assessment actually differentiated the two groups. So we have a lot of data, we're still analysing it, but right now it seems that maybe the cognitive tests aren't actually that sensitive to differentiate AFTD and autism. Maybe the ones that we use routinely aren't sensitive enough to detect the differences. It could be that questionnaires and other more social and behavioural measures might be more useful to use as a somewhat screening battery, and then depending on what they score as on the screening battery, that might prompt further clinical investigations with formal cognitive assessment or the ADOS-2 as well. So we do have the imaging data, which is still being analysed, and I'm sure that our other team members will do wonderful work with that. But we're also looking at other things like cluster analyses, or just looking at, are there commonalities between AFTD and autism? What can we learn from each type that will improve our ability to detect and diagnose? So ultimately, the project will enable greater understanding of AFTD and autism. And with that understanding, it can improve our clinical decision making and intervention as well, and also help us to create more targeted interventions for social cognition that could be a bit more transdiagnostic, so we can capture more people with the somewhat limited resources that we all recognise we have in healthcare. Okay, that is it.
So some time for questions. I can already see a hand in the air.
Thank you. Just very lovely work, great topic. I'm not sure if I missed this, but I was wondering if the AFTD and the autism, are they matched on the demographics and cognitive reserve proxy measures, things like that? So what was the age roughly and those things?
Good question. I cannot remember off the top of my head what the age range was, but we did check that there were no significant differences between the groups.
So they were matched for age, education, and things like pre-morbid IQ and...
Yeah.
Okay, interesting.
Any other burning questions? I might throw one at you. Are they the same or different?
Oh, yes.
I know this is the question that we've been burning on for years, since John Hodges presented this years ago. Is it autism or is it something else?
So we're still looking at the measures. But yeah, it is like, based on literature, we would expect them to be the same, but our data isn't really showing that right now. So we're looking at whether, is it the sample characteristics, is it the measures? The issue is that there aren't a lot of people with that AFTD. It's really hard to identify and recruit those people. So we have to work with small samples with a group that is relatively unknown. But hopefully the imaging data and our other analyses will shed some further light.
Time for one more? One more.
I should have thought slower.
There might be two more.
I was just going to ask, I'm sorry if I missed this, but was there like any, did you have a look at like the different levels of autism and the relationship between the levels of autism and in relation to AFTD?
Yeah, we haven't looked at the different severity levels of autism yet. They do the ADOS, which does have that kind of information, but we haven't looked closely at them. I think that's one of the next steps that we want to do. We just have so much data, which is exciting, as we all know, but it's also very overwhelming sometimes.
My question was about the AFTD group. It's not my area, but do they present with, if you kind of unpack a little bit, are there autistic features earlier in life? Like if you explore it, like based on this whole theory, yeah, or do they just emerge and there's really no history of autistic features earlier in life?
Yeah, so that's really interesting because a lot of the times with the AFTD, they are older as well. So they're more from our FTD clinic, so they're older than the autism sample. It's really hard to get that real rich developmental history. But there is sign of these odd behaviours throughout their lifetime, but what that's attributed to, that's what we're looking at, whether that's actually going to be similar to what we see in people with autism. I should have talked slower.
Thank you. Such an interesting topic. I was just wondering about whether or not there's any general consensus on how to characterise the atypical group. Like, is there,
Yeah, that's also something that we are working towards is that AFTD is really unknown as well, which is like we have this basic understanding, but there isn't really a general consensus, is that they do show that typical clinical profile associated with BVFTD, but they have a much, much slower progression. But our data from this project will help shed some light into, what are the cognitive characteristics, what are the clinical characteristics, and also the imaging findings as well.
It seems like a group that would be great to have performance and symptom validity tests for.
Yes. Well, I will discuss that with Olivier.
All right, well done. Thank you. Okay, excellent. So for the last 15 minutes of our session, we are going to do some more rapid-fire data blitz presentations. Okay, Natasha.
Hello everyone, I am Natasha Cordonnier. I'm a speech and language pathologist and postdoc at the Brain and Mind Centre, University of Sydney. And I'm happy to give you a quick overview of our poster titled Tracking Empathy Loss in the Non-Fluent and Logopenic Variants of Primary Progressive Aphasia, a longitudinal study. So our study stems from a key clinical challenge, distinguishing between the non-fluent, PNFA, and logopenic, LPA, variants of primary progressive aphasia. Because these two variants often share overlapping language symptoms, making diagnosis tricky. But this distinction is crucial since the underlying pathologies differ between these two variants. And recent research suggests that non-language cognitive measures, especially in the domain of social cognition, can help improve diagnostic accuracy. And one area of interest in social cognition is empathy, defined as the ability to share others' emotions, that's affective empathy, and to understand them, that's cognitive empathy. So our main question was, can empathy help in the differential diagnosis of these variants of primary progressive aphasia? And to date, only a few studies have looked into this, but they tend to report preserved affective empathy, but reduced cognitive empathy in the early stages of both variants of primary progressive aphasia. But very few studies compare these two variants directly. And interestingly, the only longitudinal study by Van Langenhove and colleagues, 2016, reported higher rates of empathy loss in the non-fluent variants of PPA, but they didn't separate cognitive and affective empathy. So the goal of our study was to take this further by investigating these two types of empathy in people with PNFA and LPA, and tracking how they change over time and how they relate to cognition, language, and care burden. So to do that, we use data from the Frontier database, including 34 participants with PNFA, 38 with LPA, and 45 healthy controls participants, matched for sex, age, education, disease duration, and disease severity. Participants with PNFA and LPA were followed yearly, in some cases for up to 9 years. And caregivers of the participants with PNFA and LPA, as well as healthy controls, completed an empathy questionnaire, the Interpersonal Reactivity Index, ROI, with the perspective-taking subscale for cognitive empathy and the empathic consent subscale for affective empathy. They also filled out questionnaires about depression, anxiety, stress, and care burden. And participants with PNFA and LPA also completed standard cognitive and language tests. We then compared groups at baseline on cognitive and affective empathy and examined how empathy profiles change over time. And finally, we also looked at correlations between empathy and cognition, language, and well-being. So what did we find? At baseline, both variants of primary progressive aphasia, so both PNFA and LPA, showed reduced cognitive empathy compared to healthy control participants, with no difference between the two variants of primary progressive aphasia. On the other hand, affective empathy was preserved, so our data or findings aligned with previous findings. But what's interesting, it's over time, we found a new pattern because we had a significant time by group interaction. Empathy, both cognitive and affective, declined more rapidly in people with LPA, which contrasts previous findings that reported higher empathy loss in the non-fluent variants. So, if you are interested or curious about why that might be and how empathy profiles are related to cognition, language, and care burden, please come and visit our poster.
Thank you, Natasha. Kayla, now it's your turn.
Good afternoon. Today I'm going to be providing an overview of our recently published paper in the Journal of Transport and Health. Before I get into the details, I just want to acknowledge my co-authors on the screen, so Professor Summers and Professor Clark, and also our funders, the Queensland Motor Accident Insurance Commission. So as we know, the population is ageing, and as part of this, we are seeing an increasing number of older adults on the roads, maintaining their driver's license for a longer period of time, as well as an emergence of these age-related diseases and conditions that ultimately affect fitness to drive capacity, such as dementia. So in Queensland, where the current study was conducted, older adults are required to undertake an annual medical assessment for driving with their GP, and they are required to do this on an annual basis from the age 75 years and onwards. So with the onus of these assessments falling on general practitioners, there is a real need to understand how they experience and conduct these assessments. So given these issues, we conducted a qualitative interview study with general practitioners to explore their opinions and experiences regarding these assessments. And we had a particular emphasis on the assessment of cognitive function and how that relates to driving, because we know that these age-related changes in cognition, as well as these neurodegenerative disorders such as dementia, can ultimately affect fitness to drive capacity. So to accomplish our aims, we recruited a total of 6 general practitioners, and they participated in a 20-minute interview via telephone. Half of the sample worked in what they classed as metropolitan areas, with the remaining working in rural or regional areas. On average as well, they had been practicing as a registered general practitioner for an average 20 years. So given the time limits today, I'm just going to talk to the findings more broadly. We did identify a total of 5 themes which are listed on the poster if you wanted to discuss these further. But generally speaking, GPs express that these assessments are indeed challenging and confronting. During these single consultations, they're required to consider a range of sources of information in making these decisions and ultimately trying to determine someone's cognitive fitness to drive. Now, this is all under strict time constraints, trying to manage competing demands, also trying to maintain the doctor-patient relationship, which we know that these assessments can impact this, as well as trying to ensure public safety of all road users. It was also noted that there is a lack of standardised assessments and guidelines, as well as training available to GPs to assist them in determining whether a patient is cognitively fit to drive or not. They also expressed that they would actually benefit from further training in this area. So whilst this study was based on a limited sample size, there are nonetheless important insights from this study, so particularly around how GPs manage and experience these cases where they suspect cognitive deterioration. It was also a key finding was that GPs are generally using global screening methods or measures such as the MOCA or MMSE, which we know only crudely measure certain cognitive functions, of which some are not even relevant to the driving task. And we recently conducted a meta-analysis on the current evidence to date, and we found that the tools such as the MMSE do not significantly correlate with reductions in driving performance in this ageing, healthy older adult population. So taken together, these findings really highlight the need for an evidence-based approach, valid and reliable assessment tools for helping GPs assess cognitive fitness to drive and to effectively triage those patients where they suspect cognitive deterioration and do triage them for further assessment. Thank you.
And for our last data blitz, welcome, Zita.
Good afternoon, I'm Zita from the Hong Kong Polytechnic University. Thank you very much for the valuable opportunity to share our cross-sectional survey study on the relationship between mahjong playing and successful aging in Hong Kong older adults. Let's start with some basic information about mahjong playing. Mahjong playing is a tile-based intellectual and social leisure activity. And on your left-hand side, you can see that there are 4 people playing mahjong together. This activity is relatively famous among the Chinese population, and it is found that almost a quarter of the older adults in Hong Kong play mahjong or cards in their leisure times. Previous study also found that it was associated with better cognitive, psychological, and daily functions in older adults. We also published a scoping review. We summarize both Western and Chinese databases and focus on the benefits of mahjong playing. So if you are interested, please scan the QR code. Okay. We found that mahjong playing is a cognitively and socially demanding activity because the players will take turn in drawing and discarding tiles. However, based on these benefits, we also identified 2 research gaps in the literature. First, the prevalence rate has not been updated. Second, the dosage effect needs further clarification. Therefore, we conducted this cross-sectional online survey study aimed to examine whether different dosages of mahjong playing would predict cognitive, psychological, and daily functions in healthy older adults. We focus on 2 research questions. First, what is the nature and extent of mahjong playing in older adults in Hong Kong? Second, what is the relationship between mahjong playing and cognitive, psychological, and daily functions in older adults in Hong Kong? We recruited 525 Hong Kong older adults and asked them to complete an online survey study. We have 2 predictors. The first one is the frequency of mahjong playing. Second is the total hours per week of mahjong playing. And then we have 5 outcome measures focusing on general cognition, executive functions, loneliness, mental health, as well as the functional independence. For the results, we firstly found that the prevalence rate among the Hong Kong Chinese older adults is 27%. And among the players, we found that they almost play twice a week and almost spending 4 hours each time. This finding is similar with the previous study, and it may represent that mahjong playing may provide motivation to sustain the leisure activity participation. And secondly, we have conducted 5 hierarchical regressions, and we all found that the 5 models were significantly. It means that mahjong playing could predict the general cognition, executive functions, loneliness, mental health, as well as the functional independence. And interestingly, we found that only the number of hours of mahjong playing predicted the functions in a positive direction. However, the frequency of the mahjong playing predicted the functions in an opposite direction. This result may imply that sufficient exposure is needed to derive the benefits of mahjong playing. In the cognitive domain, it may mean that sufficient exposure is needed to the mental exercise. And in the psychological domain, it may mean that sufficient exposure is needed to develop a social connectedness among the older adults. And for the daily functions, we found that mahjong playing may help to accumulate the cognitive reserve and generalize these benefits to the functional independence. And alternatively, we may find that the negative associations between mahjong playing and the outcome measures may be because they may spend too much time on it, and too frequent will have a negative effect. Okay, so to sum up, in conclusion, we have two main messages in the study. First, mahjong playing helps to sustain the leisure activity participation, and it may be a potential attractive activity for the cognitive training. Second, a sufficient exposure to mahjong playing helps to predict better cognitive, psychological, and daily functions of older adults. Thank you very much for spending time here and listening to my presentation. And please let me know if you have any questions, or feel free to visit my poster afterwards.
So thank you everyone for coming along to what's been a really, really fantastic and interesting session. And thank you again to all our presenters. And enjoy afternoon tea.